Hello, yes, I see that some of you have joined already. I am Dr. Matebese, as you have seen in the advert from the webpage for Fertility Solutions. I am based at Cape Fertility. I'm a reproductive medicine specialist, and I welcome all of you today. Yeah, so I'm just waiting for a few more people to join before I start talking on the topic, which is quite an important topic because, at times people don't get the opportunity to get information directly from the doctors. And at times people confuse the different terminology that we use, especially in reproductive medicine or even to say in fertility, because the terminology can be quite difficult. So I'll just wait a few minutes. Apologies for those of you who are there. Just for a few more people to join, and then I'll start talking. All right, I think we will start so that we don't delay those people who have joined on time. So the topic that I'll be talking about is intrauterine insemination. So this is a term that is often confused by many people, but just to simplify it, so intrauterine insemination basically refers to introducing sperm into the female's uterine cavity with the intention of achieving a pregnancy. So it's not the same thing as in vitro fertilization or IVF. It is at times referred to as artificial insemination. So there is a difference between artificial insemination and IVF treatment. So today we are talking about artificial insemination. And just to repeat again, meaning, so we also refer to as intrauterine insemination, meaning that you take the sperm, which has been prepared, you insert it directly into the uterine cavity of the female so that you can get a pregnancy. So then one would ask, which patients would you recommend this treatment for? So intrauterine insemination can be done with own partner sperm, or it can be done with donor sperm. So I'll first start talking about those people using their own partner sperm. So which patients who do have a sperm in their lives require intrauterine insemination? So those would be women or couples where there is a mild male factor. So the sperm still has to be quite reasonable quality because you need the sperm to be moving well. The count must not be too low for the sperm to work. And also for the female, it is important to remember that with intrauterine insemination, the sperm still need to swim and get to the fallopian tube. So you require that the fallopian tubes are patent, because if the fallopian tubes are blocked, then it means that that sperm will not be able to reach the egg because the egg is always waiting in the fallopian tube. So we would do this treatment. So as I said, if there's a mild male factor, for women with endometriosis, but again, it has to be minimum to mild endometriosis. We also do it for couples where there is what we call unexplained infertility. So say you've done all the tests, you cannot find a reason why they're not falling pregnant, then you have to introduce treatment because it could be something relating to the cervical mucus. And with intrauterine insemination, you're putting the sperm directly into the uterine cavity. It's helpful in couples that have sexual dysfunction. So it could be either from the male side, say there's erectile dysfunction and they're unable to get proper penetration for the sperm to enter the female reproductive system. Or it could be a small percentage of women have a condition called vaginismus, where the vaginal muscles just start contracting and the male partner is not able to get proper penetration for the sperm to be deposited into the right place. Also do intrauterine insemination to avoid transmission of HIV. So in this case, if it's coming for the male, you wash the sperm so that you use sperm that is free of HIV to do the insemination. If it's the female partner that is positive, then it means that they don't have to have intercourse without using a condom because you can prepare the sperm and put it directly into the female's uterine cavity. And then just talking about then indications of using donor sperm. So that would be again, so it can still be a couple, heterosexual couple, where the man has got what we call a complete azoospermia, which is not obstructive. So it means that even if you tried to get sperm from the testis, there is no sperm production happening. Hence, then the only option for those couples would be to use donor sperm. And of course, there are single women nowadays. We all have rights, and we support that fully. So if a woman is seeing that her biological clock is ticking, she doesn't think that she will find a partner, and then she has a right, she can use a donor sperm as well. Yeah. And then, of course, same-sex female couples as well, where there is no male partner, to provide a sperm sample. So how do we do the insemination? It's a very, very simple procedure. So if they're using own sperm, then usually we have to time the cycle, because timing for fertilization and for pregnancy is very important, and most couples do not realize this. So we monitor the female's menstrual cycle. So basically for some, and if you're using own sperm, especially for couples when it's unexplained, there's enough evidence, medical evidence, that the success rate is better if you do a medicated cycle. So by that I mean you add a little bit of medication, hormones, just to ensure that ovulation will happen, or that there will be release of at least more than one egg, though one has to be careful because the aim is not to create multiple pregnancies. So you'd monitor the cycle either with a scan around the 11th day of the cycle to see that there is a growing egg. Once that egg reaches the size that we want, then if it's the first cycle, we often do a blood test as well, because then once we get what we call the LH surge, that guides us, because that might actually say you need to do the insemination the very next day. Day of insemination is very simple. The male partner is asked to bring a sperm sample in the morning. So we would also have asked them to abstain, preferably for at least 48 hours before the day of insemination, but we do monitor because we don't want to miss the ovulation. The sperm is prepared in the lab. So basically, to simplify it, they will give me a collection of the best sperm. So they do what is called a wash, which means that they remove all the sperm that are not moving properly, all the ones with abnormal morphology. So then they give us in a test tube the normal sperm or the good quality sperm. So the process to prepare the sperm usually takes about 2 hours. So the male partner would have to come in the morning, drop the sperm sample, they can go back to work, and then return with the partner at the time that has been allocated for the insemination. Insemination itself happens in the doctor's room. It's very simple. It's really like having a pap smear. So the female partner lies on the bed. We insert a speculum because we need to see the cervix, which is the opening of the womb. We take a very small, thin tube, so we call it a catheter, but it's really just a plastic tube that you push in through the uterine opening, which we call the cervix, to deposit the sperm directly into the uterine cavity. So the benefit of this is that around ovulation, the mucus is quite thick, so you bypass the mucus, you're putting the sperm as close as possible to the fallopian tube. So the sperm will go to both fallopian tubes, and then whichever sperm then will have to fertilize the egg. The catch, though, is that it's still very close to nature. So there is nothing we can do after that to make sure that the sperm will indeed fertilize the egg, so it goes back to nature. Hence, we always counsel patients that the success rate is not 100%. I'll talk to about that again. Yeah. And then once we've done the insemination, the female can actually get up immediately and then take precautions, because there's a possibility of a pregnancy. We ask them to stay on folic acid, and then 14 days after the day of insemination, we do a blood test. So it can be a long wait. And we usually discourage people from doing urinary tests because it's usually early, and all that does is it causes a lot of stress. So then they will do the blood test, and then we call them. It has either worked, and then we were all very happy. But obviously, if it's negative, there's lots of sadness and tears. So in terms of donor sperm, so I was talking there about a couple that's using their own sperm. So with donor sperm, it's important to note, so in South Africa, donor sperm is completely anonymous, which means then that even when the child turns 18, they will never get identifying information on the sperm donor. You do, however, get a full profile, so you do get a whole profile that tells you the age of the person when they donated. You get their physical characteristics, hair color, eye color, hobbies, level of education, medical history. The donors are screened for most possible infectious diseases, especially HIV. We also do urine tests to exclude things like chlamydia and gonorrhea. They see a psychologist as well to make sure that there are no psychological or psychiatric issues that can be genetic, because we know some conditions like bipolar and mood disorder can actually be genetic, or schizophrenia. And then we also do a crude test for a genetic condition called cystic fibrosis. So once the donor has seen the doctor, has seen the psychologist, has done the bloods, and then they also do a sperm test, because we need to make sure that they have good quality sperm. Because remember, with a donor sperm, the sperm has to be frozen. So we have to be sure that it's good quality, so that if we thaw it out, we know that the sperm will survive and will still be good quality on thawing. So then, so once that's done, the sperm is frozen. But we still have to wait 3 months. It used to be 6 months before that sperm can be released for use because of HIV and the window period. 3 months later, the donor is asked to come back for a new HIV test, and if they're still negative, then we know then that the sperm can be released for use, and then it's put out there for patients to select that sperm donor. The other thing to note about sperm donation in South Africa is that a sperm donor can only have 6 live births at the moment. So once 6 live births have been reached, we can no longer use those sperm samples. So if a couple had selected that donor, then they have to select another one. Yeah. And then the other problem there that people struggle with then is that for a sibling, so if the donor reaches their live birth before they have the sibling, then unfortunately they can no longer use the same sperm donor, which would then mean that the children will not be full siblings. Okay, yeah, and then basically then the process of insemination is the same. The sperm will be thawed, it will be washed, and it will be inseminated in the same way. And then the other question that we always get asked is the cost. So how much does this cost? So if the couple is using their own sperm, then this would cost about 4,000 to 5,000 rands, that is including scans, medication, blood tests, and the procedure. But however, the couple will pay as we go along. So they'll first pay for the consultations, and then on the day of insemination, pay for the insemination as well. Yeah. And then if using donor sperm, obviously the cost is more, because there's the cost for the donor sperm, and that is usually, and it varies from clinic to clinic, but it's anywhere between 8,000 to 10,000 rands. And when I say this, I'm referring to per treatment cycle. So each time the couple does the treatment or the patient does the treatment, that's how much they will pay. Success rates. So fertility treatment can be disappointing. Hence, we usually advocate that people do see a psychologist just for counseling, because it can be a very tough journey. It has lots of hurdles along the way. It can be very emotionally challenging. The problem is that things can go perfectly well, but that doesn't guarantee that the result will also be what we are all hoping for. So for couples using donor sperm, each time we do an insemination, they're taking about a 25% chance that it's going to work. It sounds low, but if you think about it, we talk of normal cycle fecundity. This just basically means that for a couple, heterosexual couple, trying at home with everything normal, they usually have only about a 20% chance that they're going to achieve a pregnancy. So 25% is actually higher. And then when they're using their own sperm, it's difficult to give one success rate, because it depends on a lot of things. So it depends on the quality of the sperm. So sperm samples can vary from day to day. So if you're unlucky and on the day of insemination you have a poor sample, that can drop your success rate. Also depends on whether both fallopian tubes are patent, but not just patent, but functional. So it is a little bit lower for couples using own sperm, and it's usually about 15 to 20%, depending on all those variables. Is it safe to do intrauterine insemination? It is completely safe. It's non-invasive. You don't need an anesthetic. It's safe. We've never had, the chances of complications are almost zero. So nobody ever comes back to complain that there was a complication because they had the insemination. And then again, I just want to touch on psychological support. So we do stress this. So it is psychologically challenging, and we do recommend, it's not mandatory, but we do recommend, especially women that are doing this as single women, because we live in a society sometimes that is judgmental. The child will ask questions as well, so you need to be armed with information as to how you will answer those questions, because the child will want to know, and usually this starts at school going age when they start asking about daddy and all those questions. I think I've just about summarized it. Yeah. And then I will try and answer, because I can see that I've had a few questions. So I see that Bronwyn King, hi Bronwyn. Yeah, you asked me a question here. You say, what does pain by your ovary 1 week ovulation mean, especially when it's on the opposite side to ovulation? Yeah, so basically, if you think about what happens at ovulation, Bronwyn, so that usually means, so the follicle, or think of it as the egg bag that contains the egg, is like a water bubble. It's full of fluid. So what happens at ovulation is that water bubble bursts to release the egg. So there is always a little bit of fluid around the ovary where you ovulated, around ovulation. That can cause some irritation, and it can cause a bit of pain. So that's how some women know, actually. They can tell that they're ovulating because they feel the pain. So the initial pain is from the stretching of the capsule of that follicle. And then later on, like you say, maybe a week later, then you get more pain because of the fluid causing irritation. And then I see that I've got Nicole as well, who asked, what is the success rate for someone that has polycystic ovarian syndrome? So it also varies, like I said. That's why I said, individualized care is very important, because with polycystic ovarian syndrome, at times the problem is getting the person to ovulate. And sometimes even when you get somebody to ovulate, it still does not lead to a pregnancy. So I would still say again, Nicole, that it depends also on the sperm sample. So again, also on the age. We mustn't forget the female age is very important. So for females below the age of 35, they have a better success rate because they have good egg quality, which is very important. But more than 35, then the success rate starts to drop. So I would still, with insemination, put it at about 15 to 20%. It's not high, but I always say, when I do an insemination, I always say, you've tried sometimes for a year or two and nothing has happened. So to deal with the emotional trauma, tell yourself that you're going from 0, you're actually going to 15 to 20%, rather than think of it as 15 to 20% of 100%, because that cannot be emotionally good. Yes. And then I have another question here from, I think it's Anarisa, October. And it just says, yes, PCOS. So I'm not quite sure what she was asking there. Yeah. I'm just trying to see. So you have the opportunity, if you want to send me some questions so I can answer them. Okay. So just checking for more questions so I can answer them. Okay. And then I have someone asking me, what is the cutoff age for a couple to do IUI treatment? So that's a very, very important question. So like I said, age is important. The female age especially, because that determines egg quality. So egg quality is not something that you can do any test for. So there's this myth, there's a blood test, we call it the anti-Mullerian hormone. And people often come to me and say, can't you do my test for egg quality? So to correct that, the anti-Mullerian hormone will only tell me egg numbers, so the quantity and not the quality. So quality declines with age. So we would be very reluctant to offer you artificial insemination or IUI from the age of 36 onwards, because we know that the quality is starting to decline. So yes, it's still an option, but we usually say if the couple can afford IVF at that stage, that's usually the time to think about IVF treatment, because with IVF treatment, you're going to force the body to produce more eggs. You're going to retrieve them and inject the good quality eggs with sperm directly to increase the chances of fertilization. So basically, the reason is better is that you're not relying on that 1 or 2 eggs that will be ovulated. You're getting more eggs. So I would be very reluctant. So we can, yes, do IUI probably up to the age of 43, as long as the woman is fully counseled, or the couple, that the success rate is quite low, especially more so from the age of 40. Yes, and then just to see if there are any questions. Okay, I'm just scrolling down just to make sure I haven't missed any question. Okay, yes, there's a lot of people asking about the cutoff age, and we've discussed that, yeah. Let me see what is there, and then so someone says that they didn't, so they just want, oh, it's Bronwyn again about the pain. So we've explained why you get the pain around ovulation. Okay. Yes, I hope that this was a very informative session and that you found it useful. I'm not picking up any more questions, but I would like to say, please, if you have questions, you are more than welcome to email me directly on tmatebese@capefertility.co.za. I do not mind answering questions, so you can just email me directly for more information. You can also go on our web page, www.capefertility.co.za. So we've got documents there that go into details about artificial insemination, in fact, about all our possible treatments. Thank you.